Good morning. So topic 1 pertains to the epidemiology and natural history of diverticulitis and was broken down into 4 subtopics. We have no disclosures. So a total of 2,985 articles were collected for our topic, and we ultimately included 98 of these publications that were relevant in supporting some of the statements that you're about to hear. These were largely in the shape of well-powered prospective and retrospective studies, and the exclusion criteria are listed. These are the main subtopics for topic 1 that have to do with incidence and prevalence, associated factors and risk factors for diverticulitis, and the impact and relevance of the microbiome on development of acute diverticulitis. So question 1, we identified 67 papers that spoke to the incidence and prevalence of left-sided acute diverticulitis. We did find that admission rates for left-sided acute diverticulitis are increasing worldwide, with the highest rates of increase in those under the age of 40. This was a finding that was reproduced in numerous retrospective papers from the United States and Canada, as well as in Europe and Eastern Asia, so really a global phenomenon or trend. Some studies estimated a percent of annual change of incidence ranging from 6 to 9% in patients between the ages of 20 and 40. Moving to the next statement on this subtopic. So in patients over the age of 50, acute diverticulitis tends to occur more frequently in women with an average female to male ratio of 2 to 1, whereas in those under the age of 50, it is more prevalent amongst men with an average male to female ratio of 3 to 1. And this was also reproduced in several epidemiologic papers that we identified. Several prospective cohort studies have investigated the relative risk for the development of acute diverticulitis and inpatient admission rates in non-Western immigrants to Westernized nations when compared to natives in those countries. At baseline, the relative risk is lower. However, with time and presumed acculturation to the Western lifestyle and diet, the risk increases in a stepwise fashion to approach that of the native population, suggesting that environment plays a role in the risk for this condition. And finally, for this first subtopic, there's one more statement regarding seasonal and geographic variation in incidence of acute diverticulitis, and there does seem to be one, with the incidence and inpatient admission rates for acute diverticulitis peaking in summer months. This pattern was reproduced in both northern and southern hemispheres, and dietary changes, relative dehydration, fluctuating vitamin D levels during summertime months, may all play a role in this phenomenon.
Okay, so the next subtopic is factors that are associated with an increased risk of developing acute diverticulitis. The first statement we created is that long-term NSAID, corticosteroid, and opiate use is associated with an increased risk of developing left-sided diverticulitis. NSAID use is thought to be due to the changes in the prostaglandin synthesis and altering the colonic wall strength. Corticosteroids used are related to the immunosuppression, and opiate use due to a slower transit time, and therefore fecal stasis is induced and bacterial colonization. And the results of multiple studies show indeed that the use of these medications increases the risk of developing diverticulitis. The second statement that we constructed is that calcium channel blocker and statin therapy may lower the risk for colonic perforation and the need for emergency surgery. This has been, calcium channel blockers are thought to improve the mucosal blood flow and decrease colonic contractions, and therefore they might lower the rate of complications or of only perforation. And statins seem to have anti-inflammatory effects and therefore also decrease colonic perforation rates, and therefore these patients treated with these medications have lower admission rates for emergency surgery. The next statement we created is that an increased BMI and increased visceral to subcutaneous fat ratio are associated with an increased risk. Increased BMI, some studies have defined a BMI over 25, and some studies a BMI over 30. One study showed that patients with a BMI over 30 have a 3-fold higher chance on developing diverticulitis and a 2-fold higher chance on developing complications. One study also described that patients with underweight, so BMI below 20, also are at increased risk for hospital admission. Then the next statement is physical activity that is associated with a diminished risk. Multiple studies have investigated this. Physical activity is mostly defined as 30 minutes per day. And there's a linear association with the increased risk of, or the linear association with how vigorous the activity is and how much the risk decreases. And physical inactivity, so less than 30 minutes per day, is also associated with more hospital admissions. Then the last statement of this topic is that smoking has been associated with an increased risk of acute diverticulitis. The studies that investigated smoking present very controversial results. This is also due to the mechanism that's still poorly understood, but there seems to be a trend in higher rates of acute diverticulitis in the smoking population. And the next subtopic is, are there any other risk factors in specific patient groups? 32 articles mention specific patient groups at risk for acute diverticulitis. The first patient group is patients with Ehlers-Danlos, Marfan syndrome, and Williams-Burns syndrome that have higher rates of diverticulosis. This has been investigated a lot due to the disrupted collagen metabolism, which weakens the colonic wall and therefore predisposes this population groups to diverticulosis. But also, some studies showed that these patients are also at risk for developing diverticulitis. But this might also be due to the higher incidence of diverticulosis. They will also have higher rates of diverticulitis. And then patients with HIV and those undergoing chemotherapy are at increased risk for developing diverticulitis. This is related to immunosuppression, which has already been known to be a risk factor for diverticulitis. But as the life expectancy of patients with HIV is increasing, they're also now more at risk of developing diverticulosis and diverticulitis. And chemotherapy patients are also at risk of acute diverticulitis.
So to close out topic one, we identified 19 papers pertaining to the emerging field of the microbiome and its potential relevance and implications on risk for diverticulitis. Examination of stool samples demonstrates that patients with acute diverticulitis possess a higher diversity of fecal bacteria when compared to healthy controls without diverticulitis. Proteobacteria and bifidobacteria make up this difference in several papers in the literature. And it is thought that such organisms continuously induce immune responses and secrete pro-inflammatory mediators, and in turn put the patient with diverticulosis at risk for the development of its inflammatory complications. And the last statement for this subtopic has to do with H. pylori and its risk. So the relevance of H. pylori infection and its potential effect on the risk for developing acute diverticulitis largely remain an area of ongoing investigation, with few studies highlighting a link between the two. A 2017 prospective study of 56,000 patients examined the relationship, and those who had a positive urea breath test were significantly less likely to have symptomatic diverticular disease compared to controls who had negative urea breath tests, with an odds ratio of 0.62 that reached statistical significance.